Um, the second lecture is on the pulmonary tuberculosis. As you know, pulmonary tuberculosis is a very common chronic infection of the lung, also affecting the other organ other than lung, like the lymph node, the pericardium, the pleura, the bone, the meninges also, but commonly affecting the lung. It's caused by the Mycobacterium tuberculosis, and the main transmission is by the airborne transmission and by droplet infection also, and it's causing destruction of the lung, and is a chronic disease. If not treated, it results in a death. It is endemic in our country, especially in the north and in the south of Iraq. Before we go to discuss the pulmonary tuberculosis, we have some objective learning. Some objective learning, like, so what is the tuberculosis? Bacteria which cause tuberculosis and how it's transmitted, the predisposing factor which increasing the TB infection, pathology of TB, the cause of TB in a body, the type of pulmonary TB and their clinical picture, investigation, how is diagnosed TB, and then describe the treatment and the monitoring the TB. Tuberculosis is a chronic infection. Chronic infection is not pneumonia, was acute inflammation of the pulmonary parenchyma, but here it is a chronic infection caused by the Mycobacterium tuberculosis. Chronic infection caused by Mycobacterium tuberculosis. It is a contagious, highly contagious bacterial infection. What we are contagious and is transmitted by the airborne from person to person, mainly affecting the lung parenchyma. Contagious bacterial infection that mainly affecting the lung parenchyma. About 1/3 of the cases, other organs are affected, like the lymph node, bone, joint, spinal column, pericardium, peritoneum, small intestine, and the kidneys, and even the skin. So commonly affecting the lung, but other organs, 1/3 of the cases may affect it, include most of the other organs, starting from the skin to the lymph node, to the small intestine, kidneys, urinary tract. It also can be infected by the tuberculosis, the spine, joint, and others. More than 2 million deaths per year may be caused by the TB. More than 2 million. And the majority of these cases occur in the poorest nation. So the TB is the disease of the developing countries or the poorest country. Mycobacterium tuberculosis is a red-shaped, non-spore forming, thin aerobic bacterium measuring about 0.5 by 0.5 by 3 unimillimeter or micrometer. So this is a bacteriological finding or bacteriological character of the Mycobacterium tuberculosis. It is rod-shaped and non-spore forming. The Mycobacterium tuberculosis are not stained by the gram stain. It is neutral in the gram stain. As I mentioned, the gram stain divides the bacteria into the gram positive and gram negative. Gram positive stained by the gram, it is blue in color. Gram negative no stained, it is red in color. But we have other stain for the mycobacterial tuberculosis called the Nielsen stain. This stain was, in the previous lecture, was described by the Dr. Sumaya, how to stain the AFB, and the bacilli cannot decolorize by acid alcohol. So it is called acid-fast bacilli. Acid-fast bacilli, AFB, this is seen in the Nielsen stain, are not decolorized by the alcohol. Acid-fast bacilli. TB, it is either it is either symptomatic or latent TB, asymptomatic. So 1/3 of the world population has latent TB, or called dormant TB. This latent TB has no symptoms and non-infectious whatsoever. So about 1/3, high percentage, 1/3 of the world population have latent TB. Transmission, as mentioned, mainly it is by the droplet infection or airborne spread. Patients with active disease, which have bacilli in the lung, these are expelled into air by the coughing, sneezing, and shouting. By coughing, by sneezing, and by shouting. So this they expel the bacilli into the air or into the earth, and this then are transferred to the person by droplet infection mainly. Also, oral ingestion may lead to the tuberculosis. This occurs mainly by drinking non-sterilized or non-pasteurized milk from the affected cows. Usually it is not Mycobacterium, it is Mycobacterium bovis. This is present in the cows or in the cattle, and when the milk from these cows are not pasteurized or not sterilized and are drinking, it may lead to the TB in the intestine or in other areas also. The main transmission of the lung, the main transmission of the pulmonary TB is by the droplet infection. A few points about the natural history of the TB infection. Patients when exposed to the TB bacilli, this type of TB bacilli are inhaled, go from mouth to the larynx and to the respiratory tract. 70 to 90% of the patient non-infected. Why? Because this patient has immunity. So only 10 to 30% are infected. Those who are infected, from 10 to 30%, 90% of them develop dormant TB. And TB bacilli become in latent. Yani patient never develop TB and not infectious, but they are exposed to the TB bacilli and it's called latent TB. And those patients, because the patients are exposed to the TB, the tuberculosis become positive, but they are not infectious and no symptoms. So 90% of those patients develop dormant TB. Then only 10% of them develop active TB. And have symptoms and become ill. From this 10%, 5% develop TB within 2 years. And other 5% develop TB after many years. Those patients who are, if untreated, the patient will develop complication and severe symptoms of TB and die. 50% of them, half of them, die within 2 years if untreated. But if are treated properly, become cured. So if the patient are exposed to the TB, 70 to 90% don't develop infection, have good immunity. Only 10 to 30% develop infection. From this 10 to 30%, 90% of them Dormant TB or latent TB, which is non-infectious, and only tuberculin tests in them are positive. There is no symptom. But 10% of those develop active TB, 5% after 2 years, or 5% after 7 years. If are treated acute, if not treated, 50% will die within 2 years. I go to some factor which increasing the risk of TB or predisposing the TB. We come to the close contact of the TB patient. And the patient has TB and they live with this patient and is in the same family or are in close contact with the TB patient. So this TB bacilli might transfer to those patients. So first, close contact of TB patients. Second, overcrowding. Those who live in the overcrowding area like the prisons, سجن, schools and institutions, المعاهد. First, immunosuppression, especially those who use high-dose steroids, cytotoxic agent, or have malignant disease, also their immunosuppression. Other malignancy also can cause immunosuppression, like the lymphoma leukemia, diabetes mellitus, and chronic renal failure, also may lead to the immunosuppression. Gastrointestinal disease associated with malnutrition also can impair the immunity. And the last is deficiency of the vitamin A and D, also can lead to the response to TB. So response to TB, close contact of TB, overcrowding in the prison and other area, immunosuppression either caused by a drug or by the disease, like the lymphoma, leukemia, diabetes, gastrointestinal tract, malabsorption, cancer of the pancreas, and also vitamin D and A deficiency. This diagram illustrates the pathogenesis of the tuberculosis. Or first, the TB is inhaled. TB bacilli is inhaled. It go to the trachea, bronchi, bronchus, and releasing to the alveoli. In the alveoli are there is phagocytosis of bacilli by alveolar macrophage. Alveolar macrophage present in the alveoli, this phagocyte the bacilli, and also this secrete the interleukin 12 and 18. And this interleukin 12 and 18, this result in the stimulation of inflammatory cell, result of the inflammatory cell to come to the area, to the site of the lesion. So alveolar macrophage secrete interleukin 12 and interleukin 18. Interferon gamma, which is secreted by the lymphocyte, induce the bacterial killing. Tumor necrosis factor alpha is essential to control mycobacterial growth and granuloma formation. So, macrophage, by secretion of the interleukin alpha and 2, they stimulate also the lymphocyte, and this lymphocyte will become infected. It secretes the interferon gamma and also it secretes the tumor necrosis factor. Tumor necrosis factor, it results in the tubercle formation because the bacilli here are become engulfed by the cell and result in the central necrosis, and this is surrounded by the many cells, which is like the lymphocyte, giant cell, and epithelial cell, and other. These are surrounding the mycobacteria, and mycobacteria become center and develop necrosis. This is called caseating granuloma. This results in tubercle formation. Tubercle formation, how it occurs when the bacteria go to the lung. It is surrounded by the many inflammatory cells like the lymphocyte, epithelial cell and the giant cell. And these are surrounding the mycobacteria, and this results in the necrosis of the central necrosis. This is called caseatic necrosis. So the tubercle will form in the lung, which is in form of the granuloma. Granuloma consists of the central core of the caseatic necrosis, outer wall of the epithelioid cell, lymphocyte, Langerhans cell, and the neutrophil, and inside there is caseatic material. This is called caseatic granuloma. This caseatic granuloma is the hallmark of the TB. And this caseatic granuloma become coalesced together. So numerous granuloma aggregate to form the primary lesion in the lung called gone focus, usually occur in the upper lobe of the lung. And this stimulates the lymph node, or transfer to the lymph node, result in the lymph node, regional lymph node enlargement. So gone focus or primary lesions and then regional lymph node enlargement called gone complex or rank complex. This is the hallmark of the primary TB. And this lesion is usually appear on the X-ray or calcified, appear as calcified shadows, calcified lesion and calcified lymph in the X-ray. And this is the pathology of the primary TB. We come to the fate of the primary tuberculosis. So this, as I mentioned, how tubercle enter the microtubules into the lung, and how this problem started by the macrophage, and how it formed the granuloma. This is the primary TB. So what is the fate of the primary TB? Spread from the primary focus to the higher intestinal lymph node to form primary complex, which is in most cases healed spontaneously by fibrosis and the calcification. As I mentioned, when the primary lesion occur in the upper lobe in the lung and lead to the enlarged localized lymph node or regional lymph node, which is called the gone complex or gone complex, and this usually healed either spontaneously or by treatment and become calcified also. Or there may be direct extension of the primary focus lead to the progressive pulmonary tuberculosis. And this focus of lesion might extend to the bronchiole and go to the other area, lead to the progressive pulmonary tuberculosis. Or maybe extend to the pleura, result in the pleural effusion, TB pleurisy and pleural effusion. Or by extending to the blood and go to the other area, lead to the primary miliary TB and even lead to the meningitis also. And this is the fate of the primary TB. This is the gone focus, and this is the regional lymph node. In many cases, these are healed spontaneously and become calcified. Calcified gone focus and calcified the lymph node. This appears on the chest X-ray as calcific lesion. This leads to the old healed TB. Or it spread to the lung, leading to the progressive pulmonary TB, spread to the lymph node, or spread to the pleura, resulting in the pleural effusion, or may pass to the blood vessel and resulting in the miliary TB or TB in other areas like TB meningitis, TB of the bone, and other also. We come to the natural history of the untreated primary TB. If this primary TB untreated, what happened to it? At time from the infection, 3 to 8 weeks, primary complex will develop, and lesion in the lung and in the regional lymph node called primary complex, and the tuberculin test become positive also. 3 to 6 months, patient blood يعني البacilli ما passing to the 3 to 6 months, the bacilli may pass to the blood vessel and may to the biliary TB or meningitis, or may pass to the pleurocozic pleural disease. 3 to 6 months. Up to 3 years, patient may develop gastrointestinal, bone, and joint and lymph node disease also. From 3 years onward, the patient may develop post-primary disease. Post-primary disease either due to the reactivation of the dormant TB bacilli or reinfection. The type of the TB, we have subclinical or latent TB, primary pulmonary TB, and post-primary TB. Subclinical or latent TB, this is very common and important. In most cases, infection of the healthy individual is subclinical. When the patient are exposed to the TB and develop TB, 90% of them, 90% of them may develop dormant TB. Only 10% develop active disease. Dormant TB is subclinical. The patient has no feature or symptom of TB and is non-infectious. Only is detected by the tuberculin test become positive. About 1/3 of the population develop latent TB. Detection of the latent TB, the test used is by TB test, tuberculin test. We inject the purified protein of the TB bacilli intradermally, and after that the result will become reaction. There is nodule will occur at the site of injection, and this nodule is become more than 10, it is positive. So patient has exposed, it means the patient has exposed to the TB, or the patient can diagnose, or the patient has BCG vaccination. Or is the other test called interferon gamma release assay, IGRA. Interferon gamma release assay blood test. Also, this can detect the TB. Interferon gamma, this is substance is secreted from the infected lymphocyte. So it is increased in patients who are exposed to the TB. So IGRA test also means the patient are exposed, but cannot differentiate that the patient had active TB or latent TB. But the TB skin test is positive mainly in patients with latent TB. So prediction of the latent TB by TB skin test or by the IGRA test. We come to the primary pulmonary tuberculosis. How it present? And most of the cases may be asymptomatic, or there may be influenza-like illness. And patient develop fever, headache, myalgia, mild cough also, and some respiratory symptoms. And very difficult to be diagnosed. But his skin test conversion and TB test was negative and changed to become positive. Tuberculosis test is positive in this patient. Or patient may develop a pleurisy and pleural effusion. Or rarely, patient may develop segmental or lobar collapse. Patient may have cough with dyspnea, and in the X-ray there is segmental or lobar collapse. Or patient may develop obstructive emphysema. So the cough, dyspnea, shortness of breath also. Or the bacilli are passing to the other area, to the capillaries or the blood vessel, and resulting in the meningeal TB, meningitis, and pericarditis. So presentation of the primary TB are asymptomatic or influenza-like illness. There is tuberculin test become positive. There may be pleural effusion. There may be segmental or lobar collapse, obstructive emphysema, or Patients may develop biliary TB, meningitis, and pericarditis. The X-ray findings in the pulmonary TB are: there is hilar leaf adenopathy. Enlargement of the hilar leaf is usually unilateral. Can be bilateral, but usually unilateral. Bilateral usually occur in the sarcoidosis. Bilateral could occur in 1/3 of the cases, and here should be differentiated from the sarcoidosis. But unilateral is characteristic of the TB. Primary lesion, the lesion plus regional lymph node called Gone complex or lung complex. It appears as there is the opacity in the lung, small opacity, usually the upper lobe with the enlarged lymph node. And this may be calcified, appear only as calcification. Here you see this patient. This is the lymph node here. In the right side, the left side of the lymph node, this is the lymph node. This right paratracheal and left hilar adenopathy. This occurs to the primary TB. This is the called hilar and left hilar lymphadenopathy, left hilar lymphadenopathy or paratracheal lymphadenopathy. This occurs usually to this primary TB. One presentation primary TB is the paratracheal or hilar lymphadenopathy. This hilar mainly. This paratracheal. Paratracheal is right side and left hilar. So this left hilar is more prominent. This mainly TB could be due to malignancy, but mainly this is due to the TB. Here, what you see here, this calcification, this calcified spot. This is the Gone focus, and this is the calcified lymph node. This is called Gone complex. This patient has bilateral hilar neuropathy. The symptoms is either TB or could be sarcoidosis or fungal infection also. But this could occur also in the primary TB. This bilateral hilar neuropathy could be of the TB or mainly of sarcoidosis. We go to the post-primary pulmonary TB. The most common and frequent form of TB is post-primary TB. The TB lesion which is seen in the most of the medical ward or in the hospital, in the TB center, most of them are post-primary TB. The post-primary TB result either from a new infection or reinfection or reactivation of the previously dormant infection. And patient either newly infected and develop the post-primary TB, or patient has dormant infection or late infection and reactivation of this TB due to the many conditions and reactivation result in the post-primary TB. The lesion here mainly occur in the apex of the upper lobe. At 80% to 90% occur in the apex of the lung. The incidence usually is insidious and develops slowly over several weeks. Patient with post-primary TB has two features: systemic symptoms and pulmonary symptoms. Systemic symptoms: patient may develop fever, low-grade fever, night sweat, malaise, loss of appetite, and weight loss because of the poor appetite. These are systemic manifestations of TB, mainly fever, low-grade fever, night sweat, malaise, anorexia or appetite, and weight loss. The pulmonary symptoms include the chronic cough with a sputum, pre-symptom, or there is hemoptysis also. There may be chest pain, there may be shortness of breath, or the patient may develop many pathology in the lung. So, the pathology which occur in the lung in patient with the post-primary TB. There will be cavity in the upper lobe. There will be consolidation or collapse also in the upper lobe. Patient may develop pleural effusion, or patient may develop diffuse medullary TB also. This is the pathology in the lung. May develop effusion, may develop collapse, may develop the consolidation, may develop cavitation, and others. We come to the clinical presentation of the post-primary TB. A patient with a post-primary TB, how it is present? The commonest one, patient has a chronic cough, often with hemoptysis, and no response to the usual antibiotic. Chronic cough with hemoptysis and no response to antibiotic. Usually, the patient may have fever, night sweat, anorexia, weight loss with it also, and no response to the antibiotic. Or patient may only develop fever without problem manifestation, like fever called fever of unknown origin, PO. As mentioned, there is weight loss and general debility, poor appetite, or patient may have pneumonia. And this pneumonia not responding to antibiotic. The patient after 3 weeks, 4 weeks, there is no resolve, the pneumonia not resolved, called unresolved pneumonia. Or patient develop lung collapse. You have the chest pain, shortness of breath, and extra lung collapse. Or can causing TB pleural effusion. Or will be asymptomatic, only detected by the routine chest X-ray. So TB has many, as mentioned, mainly there is the systemic manifestation of the low-grade fever, night sweat, anorexia, weight loss, malaise, usually with the chronic cough, with the shortness of breath, with hemoptysis, and this not responding to antibiotic. Or may present only with the PO, or the fever of unknown origin, without pulmonary manifestation. Or can cause pneumonia, and this pneumonia not resolved by antibiotic. Or causing lung collapse. Patient has feature of lung collapse, usually present with a chest pain, shortness of breath, cough, and by chest X-ray, is lung collapse. Or can present with a pleural effusion, extend to the pleura and causing pleurisy and pleural effusion. Or rarely may be asymptomatic when detected by routine chest X-ray. There are some differences between the TB infection and TB disease. TB infection, a patient exposed to the TB but don't develop symptomatic disease. This is called latent TB. So patient with a latent TB or patient with active TB. A latent TB, there is no symptoms. Patient does not feel ill or sick. Patient is not infectious, cannot spread the TB bacilli to others, not infectious. Usually has positive skin test. And X-ray usually is normal. And sputum has no sputum, even sputum done, there is negative sputum smear. So patient with TB, there is no any symptoms. The only thing it is the positive tuberculin test, and the X-ray was normal, and is non-infectious for other. Patient with active TB usually have symptoms of the cough, pre-sputum, hemoptysis, fever, weight loss, and other. Or patient may develop chills, fever, and night sweat. Usually appear ill, sick. And this may be infectious to the other, especially if patient has open TB, يعني TB bacilli present in his sputum, so will be affixed to other. And usually X-ray is abnormal in form of the cavity or collapse or pneumonia or consolidation, or there may be pleural effusion, or there is maybe diffuse opacity of the lung also. A smear may be positive, and sputum smear may be positive by culture or even by the AFB may be positive. And this patient needs treatment to active TB also. What are the chest X-ray findings in the pulmonary TB? Diagnosis of the pulmonary TB is by the clinical feature plus the chest X-ray finding plus the positive AFB inside the sputum or by the culture. The X-ray may be normal, it is rarely. So normal chest X-ray, not excluding the TB, or there is unresolving consolidation, or there is collapse. This collapse may be lobar or segmental. There may be cavity inside the capacity, or there may be merely diffuse shadowing, or there is pleural effusion or empyema. These are the features which appear on the chest X-ray. See here, this is the gross appearance of the TB lesion with cavity. This is the chest X-ray. Usually, as I mentioned, the TB lesion, post-primary TB, occurs in the upper lobe or in the apex. This is non-homogeneous opacity and there is cavity inside it. This is the cavity. This is the non-homogeneous and this cavity inside it. And this is the gross appearance of the TB lesion. This is the TB lesion. Here also, the bilateral upper lobe involvement seen in this patient with a post-primary disease. Here, there is lesion and also there is lesion. With this advanced post-primary TB in immunocompromised patients. Here there is non-homogeneous opacity, and this also is cavity formation here. So, and we see here also advanced TB with fibrosis affecting the upper lobe, and this multiple cavity inside it also, and non-homogeneous opacity on both sides also. And this is chronic TB. There is also lesion with cavity and even fibrosis. You see, this is the lesion and this cavity and this other lesion also. This is the cavity. This is the medial TB. You see, both lung are involved. There is the multiple tiny nodules in both lungs, multiple tiny nodules in both lungs here affected, and this acute condition and emergency, if not treated urgently, will result in death. This is the miliary TB affecting both lungs. Miliary cysts or miliary tiny nodules in both lungs. Also, this post-primary TB, advanced post-primary TB, affecting the both upper lobe with the cavitation also. So this is about the X-ray finding of the TB. So for diagnosis of TB, I mentioned page to have clinical feature of TB, systemic and the program station. Second, typical chest X-ray changes. And third, we should detect the TB bacilli either by the sputum, detected by the AFB which positive, And direct microscopy of sputum remains the most important first step. Sputum for IV become positive by Zielnitzer's stain or by Oramin fluorescence stains. Usually commonly used Zielnitzer's stain. Or if not positive, we do the sputum for the culture. But this may need 4 to 6 weeks. What gives the best result also? Or now we do the PCR for the nucleic acid amplification. And the test which used here, it is called gene expert test. The expert they detect the PCR of the Mycobacterium TB and also detect if there is any resistance to the rifampicin. And the result will come in a matter of hours. Gene expert test usually we use the sputum for this also. So for detection of the AFB or Mycobacterium is either by the Zielnitzer's stain, direct sputum smear. We collect the sputum for 3 days. We usually take the morning sputum and we examine 3 specimens of sputum for 3 days. If it was positive, it's diagnosed. If it was negative, not exclude. We do the blood culture and sputum culture, or we do the gene expert or PCR, gene expert and rifampicin resistant test also, RIF test. We have also other tuberculin test and gamma interferon release gamma interferon release assay test. These detect mainly the subclinical or latent TB. Cannot differentiate that this TB is active or latent. Or we took the biopsy from the infected tissue and biopsy from the lymph node, biopsy from the pleura also. So for diagnosis of TB, we do the clinical feature, chest X-ray finding, and detection of the Mycobacterium tuberculosis either by the sputum for the AFB, become positive. Negative not excluded, we do the sputum for the culture for TB, or we do the PCR by gene expert test also. And also you have the tuberculin test and the gamma interferon release agar assay, or biopsy on infected tissue like biopsy from the lymph node, biopsy from the pleura. Immediately you take the pleural liver biopsy also, or bone marrow biopsy. Sputum smear stain by Zielnitzer's stain. We take the 3 morning successive mucopurulent sputum. 3 morning successive mucopurulent sputum sample are needed to diagnose the pulmonary TB. Not only one, we do 3 morning sputum. If it was negative, not exclude, we do the culture. If it was positive, it is diagnostic. The culture of the sputum, the definitive diagnosis depends on the isolation. The definitive diagnosis depends on the isolation and identification of the Mycobacterium tuberculosis from the diagnostic specimen in egg or agar-based medium. So I read this for the Dr. Sumaya. She described how to culture it, but the culture sputum, the culture called Lorenstein Jensen, and there is other tests, and usually need 4 to 8 weeks. The result may be result after 4 to 8 weeks. So by the culture of sputum, give the definitive diagnosis. I mentioned also gene expert RIF test. This combines the potential to diagnose the TB and detect the presence of the rifampicin or rifampicin resistance also. Here is the culture, how it appears the colony of the Mycobacterium tuberculosis. This is detected by the culture also. We have solid culture and liquid culture. So 8th week growth of the Mycobacterium tuberculosis on Lowenstein Jensen agar. The interferon gamma release assay. interferon gamma read assay. Interferon gamma read assay blood test is a blood test screen for exposure to the TB by indirectly measuring the release of the interferon gamma from sensitized T cell in response to the antigen specific to the mycobacterial tuberculosis. Here, the interferon gamma read assay is a blood test. If it was positive, it means the patient is exposed to the TB. We measure the interferon gamma, which is released from the T lymphocyte or from sensitized or the infected T lymphocyte in response to the antigen specific to the mycobacterial tuberculosis. So IGRA are immunological tests, are not influenced by the BCG vaccine. Because we have tuberculosis test which is positive if the patient received BCG vaccine. But IGRA are immunological tests. IGRA are immunological tests are not influenced by BCG vaccine and almost non-TB mycobacteria also. Positive IGRA test it means that the patient like to have been exposed to the TB and patient may have latent or active TB. So positive IGRA it means the patient are exposed to the TB and the patient may have either latent or active TB. So cannot differentiate between the active TB or latent TB. But it means the patient is exposed to the TB and not affected by the BCG vaccination. So the IGRA test, it detects, it is a blood test, measure the amount of the interferon gamma released from the sensitized T cell, and this is positive when it means patient are exposed to the TB but don't differentiate the active and chronic TB, are not affected by the BCG vaccination. Tuberculosis test, here we inject the purified protein derivative of the TB bacilli. We inject it intradermally in the side skin, in the inner surface of the forearm, and the nodule will occur at the site of injection after a few hours. And usually we measure this nodule. If it's more than 10 millimeter, indicate the TB test is positive. If patient develop positive TB test, what it mean? It means there is previous exposure to the mycobacterial TB. Patient have positive TB test, it means the patient has previous exposure to mycobacterial TB either by BCG vaccination or by previous infection and active infection. So here is different from the IGRA. IGRA not affected by BCG vaccination, but cannot differentiate between the previous and active infection or related active infection. So if the patient has BCG vaccination, it's better to use the IGRA test. This can not affected by the BCG vaccination, but cannot differentiate also between the latent and the active infection. The diameter of the nodule in the TB test to be positive should be more than 10 to 15 millimeter. So we cover the TB from the cause of the TB, transmission, some epidemiological aspect, pathology, fate of the TB bacilli, clinical picture, investigation, and diagnosis. Now we go to the treatment of the TB. Here for you as a second year, I I speak short notes on the treatment because I don't go to detail. Treatment of the TB, it is the bacterial infection. It needs antibacterial drug. Antibacterial drug. We have the first line drug and second line drug. Only here for you, I go to the first line drug. We have 5 drug which is first line. As I mentioned, this is the INH or isoniazid, rifampicin, parazinamide, ethambutol. These 4 drugs are given orally. And the last one is streptomycin, which is given intramuscularly. This is the first line drug. The first 4 are given orally and well absorbed, and the peak serum level is at 2 to 4 hours, and nearly complete elevation occurs within 24 hours. For treatment of TB, usually use the combination chemotherapy. We don't use single drug because this results in more resistance, because the TB bacilli are dormant and it needs prolonged treatment. We usually use the combination of the drug. At least we use the 4 drugs. And the drug which is first used are those drugs, the INH plus rifampicin plus parazinamide plus ethambutol or plus streptomycin. Usually we prefer ethambutol because orally streptomycin this injection. So we give this drug, and this drug is given for at least 6 months. Most patients are effectively treated with the 6 months chemotherapy. Some of them may need 9 months and some other may need 12 months. But as the classical treatment or for the uncomplicated TB, pulmonary TB, it is the 6-month chemotherapy. A treatment divided into the 2 phases. The initial intensive phase, bactericidal course, and the continuation phase, sterilizing phase. The initial intensive phase, this needs 2 months. This rapidly reduces the bacterial population, result in it kills most of the bacteria. It is bactericidal. But some of them are remained, then are followed by the continuation phase or sterilizing phase, which we give for the 4 months. So the total are 6 months treatment. The initial intensive phase 2 months and the continuation phase or sterilizing phase are 4 months. This destroys any other remaining bacteria. Phase 1 kills most of the bacteria, but some of them remain. By the continuation phase, destroy any other remaining bacteria. The standard treatment regime. In intensive care, we use for 2 months with the 4 drugs. The INH, isoniazid, rifampicin, parazinamide, ethambutol, orally or streptomycin. This is the intensive phase which kills most of the bacterial population with the 4 drugs for 2 months. Isoniazid, rifampicin, parazinamide, ethambutol, and streptomycin. Continuation phase, this for 4 months with the INH and the rifampicin to kill all the remaining bacteria. This drug, which is given orally, should be given in a single dose. Single dose, morning dose before meal. Don't divide the dose. Streptomycin is given intramuscularly either daily or every other day. Patient if is less than 44 years 45 here, we give him daily. More than 45, we give every other day, because Streptomycin affecting the vestibulocochlear nerve, mainly affecting the vestibular branch of the eighth nerve. It may result in the tinnitus of the ear and impair of the hearing on the vertigo also. So it is better to be given every other day. You should give this drug, the patient should have idea about the side effect of this drug, because it is used for the 6 months at least. This drug show, some of them with the side effects show, the patient and the doctor should have a good idea about the toxic effect or side effect of this drug. The common side effect of ILH can cause hepatitis and peripheral. For rifampicin also can cause hepatitis and jaundice and arthritis, or can cause the color of the tear urine which change to the red orange. Also can cause hepatitis, or color of the tear and urine, color of the fluid become change to the red orange. Streptomycin is ototoxic, can damage the vestibulocochlear nerve or eighth cranial nerve and result in the vertigo. Risabitol also is given orally. This can affecting the optic nerve, the optic neuritis, decrease in the visual acuity, and the color blindness. So if the patient receives risabitol, should be regularly examined by the ophthalmologist to see if there is any evidence of the optic neuritis. Parazinamide also can cause hepatitis, hyperglycemia, or joint pain. This is the main side effect of the TB drug. Treatment monitoring. The patient should be monitored by the examination of sputum. The effectiveness of therapy for primary TB is assessed by further sputum smear. Usually at 3 months and also at 5 months. And if the patient receives anti-TB, we don't leave them, we follow them. Now this patient respond or no. The patient may develop sometimes resistant, or the patient may develop treatment failure. So it is assessed by the sputum smear. Further sputum smear either by the culture or by the AFB stain after 3 months and 5 months. Usually by culture is better. If culture become negative after 3 months and 5 months, it means the patient he received treatment, become cured, or he respond to the treatment. And also at the same time, we monitor the drug toxicity. So what we do for the patient, liver enzyme, serum bilirubin, because the patient may develop hepatitis also. We assess the visual acuity of the patient by ophthalmologist also. And we ask the patient if he develop any pain in both leg or foot, because the patient may develop peripheral neuropathy. A treatment failure. Patient may develop treatment failure. What is treatment failure? Treatment failure is patient's sputum culture remain positive after 3 months. Or AFB smear stain positive after 5 months. Treatment failure, at which time you can see this patient has treatment failure. If the patient receive proper anti-TB and after the 3 months the culture was still positive, or after 5 months the AFB smear also is positive. This means the patient has treatment failure. The treatment failure either due to patient received unproper antibiotic or was not adherent to the antibiotic also. Antibacterial given either daily or sometimes may given by dot. يعني dot should be given and dot under observation. The drug should be given under observation. يعني we not given daily. The patient come to the center or the one of the those who are dealing with the TB. They go to the home of the patient and the patient receive the drug in front of the doctor or a friend of the those who deal with the critical care or with the who dealing with the treatment of the TB. The patient receive drug in front of the doctor or a friend of the those who are working in the TB center. And the drug should be given either twice weekly or 3 times weekly. This is not for all the patients, for the patients who are not receiving the drug properly, they are mentally retarded or have some problem also, or they live alone in the home. It's better to be given drug in the front of the doctor or the man who dealing with the anti-TB drug. Prevention is by diagnosing the infectious case rapidly and administer treatment until cure by BCG vaccination and treatment of the latent TB infection also. I stop here. I don't go in detail of the treatment. For latent TB, the patient may receive either the anti-TB or may receive only the rifadin and the INH for the 3 months also for latent TB. So up to here I stop. In the fourth field we go more detail on the treatment. For you now is enough about line of the management of the TB. Thank you for your good attention. I hope that you are going to benefit from my lecture. With thanks.